Can I predict the difficult cholecystectomy? In many ways, I've already talked about that. So what are the exit strategies that you can use, or what do you do when you're there? And I'm just going to show some examples from some of the work that we've done. I have no disclosures. I always try to have a strategy. I look at the imaging studies. I get a CT if I've got someone who might have a more inflamed gallbladder. I think about my patient. I calculate their Tokyo grade, determine whether I might have to open. How are they going to do with an open operation right now? Do I have to do something else, get them in better shape before I convert them to an open operation? In my line of work, that's a real consideration, and I always have a bailout plan. Should I get a cholecystostomy? I think that's a really reasonable thing to think about. I use it a lot, and I'm very good at getting these tubes out and getting the gallbladder out with it. We've talked about the bile duct injuries. You've got to think about the active and the passive mechanisms, and these are important considerations when you're thinking about prevention of bile duct injuries and how these things can happen. Years ago, Dr. Wei and I wrote a paper on human factors where we quantified a bunch of rules of thumb, which I'm not going to go through in a lot of detail here, because I'm going to talk about them during the talk. But here's our reference, and you can see, and you should basically, whenever you see something that's confusing, whenever you see something abnormal, you've got to investigate it. But the thing that was fascinating is I was going through this, and I read this rule of thumb, factors that suggest the common duct might be dissected. One was the cystic duct is not encompassed by a 9mm clip. And then the other ones, of course, if you can trace it to the duodenum, if you have an unexpected ductal structure, if there's a large artery behind it, extra lymphatics, etc. But I thought about that 9mm clip. And I thought that's our mental model. That's our surgeon's mental model of the common duct. Why? Because when we operate on the common duct, it's generally got pathology, it's generally dilated. So when we think common duct, we think it's big. And so if I'm clipping it, it might not fit through the clip. But the truth is, the common duct is generally just exactly the right size to fit that 9mm clip, because the normal common duct is 5mm. Now, what about routine intraoperative cholangiograms? Here's, you always got to get you have to see the following things. You've got to see the hepatic ducts, the common hepatic duct, the common bile duct, the duodenum, and you've got to see the cystic duct. If you don't see the cystic duct in your cholangiocatheter, your cholangiocatheter might be in the common duct. So that's really important. I always make sure I can see a piece of the cystic duct. So if you don't see the proximal ducts, if it's narrowed, or you don't see a pit of cystic duct, that's abnormal. You've got to figure it out. Now here's an intraoperative cholangiogram, and I want you to take a look at these. Notice a couple things. Well, first of all, they're really obvious. They've obviously mistaken the common duct for the cystic duct and clipped it. But I want you to notice one very interesting feature here. Look how little that common duct is. This cute little thing is more narrow than that grasper, and this one is about the same size. And we all know the graspers fit neatly into a 5mm port, and there's room to spare, which means you're talking about probably a 3 and a 4mm common duct. And that's probably why it was mistaken so easily for the cystic duct. Now, what you've got here is this, as I've drawn a little picture of it. You've got the cholangiocatheters in the common duct. They've clipped the common duct above it, and you've got the gallbladder. And you can see the common duct might be really small. You really don't know what the inflammation in the gallbladder area might be, and why do they have the misidentification. And so, I mean, from a simple standpoint, well, simple. You pull the clip off, take out the cholangiocatheter, take out the gallbladder, and then all you really need is a little stitch. But if it's a really tiny duct, then you have to be sure that you're comfortable stitching a 3mm duct. If you don't recognize it, then you're going to get a class 3 injury where you resect the bile duct. So if those were post-op, those people were not recognized, and they ended up with a class 3 injury. Here's another set of cholangiograms. Now you see narrowing of the common hepatic duct. These are intraoperative cholangiograms. And now these guys are going to need root-wide reconstruction, because it's not going to respond to dilatation. You can't do it. You can't repair it primarily. Place a drain. Refer this to a biliary specialist. Only remove the gallbladder if it's already been dissected out. If you're really or if you're really confident that taking it out won't cause further injury, because there's a reason you were dissecting in that plane in the first place that caused that cholangiogram. So always ask yourself, what do I do now? Now that I've detected the bile duct injury, what's my next step? So you got to keep calm and avoid maneuvers that might worsen the bile duct injury. That's really the most important thing. Here's another intraop cholangiogram. Interesting, looks pretty good, really? But in fact, this is in the right sexual duct, which was mistaken for the cystic duct, and this person needed a Roux-Wire reconstruction of the injured right sexual duct. So you can have cholangiograms that are misleading as well. Now remember that, again, we talked about that most of these are not recognized, and the most important thing is changing the frame. You got to really actively look for trouble. Got to be like Sherlock Holmes. And then, we talked about the clues that you're detecting in the wrong plane: ductal tubular structure, cystic duct not encompassed by the 9mm clip. Maybe that's not even just good enough. Cystic duct can trace it to the duodenum. That's the common duct. Accessory duct, don't call it a ductal. Bile draining from a ductal tubular structure, failure to pacify the ducts, narrowing, and additional features. I'm going to talk about some of these, but you got to frame all these as a bile duct injury. If you see bile, try to figure out where it's coming from. If you're sure it's not coming from the gallbladder, try and figure it out. Always leave a drain. Just always leave a drain. Think if you see it from a tubular structure, that's an injured bile duct. Get a cholangiogram if you can. Don't assume it's a ductal Lygia. If it's only 3mm, don't assume it's accessory or anything else, because you can have normal biliary radicals that are 3mm. Extratubular structures. Well, it could be the right hepatic artery. It could be a common hepatic duct. You have to assume if you see a tubular structure that it's the common duct or the common hepatic duct. You have to have a high index of suspicion. Don't think it's just something accessory or a ductal Lygia. Anomalous anatomy. This was interesting. These are some of the descriptions that we got on some of the op reports from the people with bile duct injury. Cystic duct more medial than usual. Of course, the common duct is medial. Extra lymphatics around the cystic duct. The common duct has those. Abnormal long gallbladder infundibulum. As you follow down the common duct, it'll go into the duodenum, right? So if you're dissecting out the common duct thinking it's the gallbladder, you're going to think it's a long infundibulum that goes toward the duodenum. And then redundant infundibulum, that also might be the common duct, or fibrous tissue in the gallbladder bed. We saw that in cases where they transected the proximal hepatic duct. They described the cues, they just didn't know what they were. Of course, the right hepatic artery passes behind, which I've already made that point. Severe hemorrhage, obviously this is the mechanism for the passive injuries. Now you're probably involved in the right hepatic artery, which means you're probably involving the right hepatic duct. Or you might have a replaced right hepatic, and that can be a problem. We've seen cases where the dissection was actually in the portal structures, and this is really the mechanism of these non-resectional bile duct injuries. You have to control the hemorrhage, consider opening, but also make sure that when you open, you remember to really look carefully for a bile duct injury. Ductal abnormalities, always get a cholangiogram, no matter what. If it's an accessory duct, it's not a ductal Lygia, it's a cystic duct or ductal tubular structure, it's a duct. If it's short, the short cystic duct might mean that you actually haven't released that tissue between the infundibulum and the cystic duct, although there can actually be short cystic ducts, and I do think that's a mechanism. And if you can trace it to the duodenum, it's always the common duct. Here's a non-routine operative cholangiogram where they suspected a bile duct injury, and you can see now they see the biliary radicals up above. So what do you do now? Get help! And misery loves company, right? But actually, again, there's no hurry to repair this bile duct injury. If you're still laparoscopic, you've already identified the injury. The only thing you need to do is have laser focus that what you need is to maximize the possibility of a successful bile duct injury repair. And in most cases, if you've detected it early enough, opening is not your friend, because all that does is add inflammation to the scene and make the reconstruction easier. Unless there's somebody in your hospital that can come right now and wants to tackle this right now, who repairs these every single day of the week, you probably should put this off, put it in a drain, and come and play another day. And even if that person is in your hospital, they may want to check the patient out, talk to the family, know what's going on, and make sure that they start that day nice and refreshed rather than, 5 o'clock at night. So I think the key here is not to be in a big hurry. And if you look at these injuries, you can see here's an injury picture. You see here's the stump. Here's the transected right hepatic artery. This is pretty common. Here's the stump of the common hepatic duct. You can see it's pretty embedded in the tissue. As you go forward, now we've got it kind of cleared out, ready for the dissection. You can see here's your 9 millimeter clip. You can see it's considerably less than that. It's probably about a 6 millimeter duct. So again, what actually affects successful reconstruction, you guys saw other people going to talk about this. The most important, eradicate intra-abdominal infection, but of course, if you've dissected it intraoperatively, prevent it. So put in a drain, get the patient to the specialist, everyone's going to be happier. Obviously you need cholangiography, right technique, and an experienced surgeon. Timing doesn't really matter. It only matters for eradication of the abdominal infection. So have a strategy, change your mental model, look for abnormalities, assume normal ducts can be very, very small. Remember, the normal common duct is 5 millimeters. Don't disregard anatomic abnormalities. Use them to figure out where you are. Obtain cholangiograms liberally. And if a bile duct injury occurs, refer the patient to a biliary specialist and maximize preoperative preparation. Thank you.